Welcome back, everybody. It's a world virtual coronavirus virtual conference, and we are continuing to bring the speakers around the world, the experts around the world, to understand what is going on with the pandemic and what is going to happen. So today I am honored to have Will Ibbotson. He is a very unique speaker, and he's going to give us a really good added value because he's a medical officer, Royal Flying Doctor Service, Southeastern Section of Australia. Welcome, Will.
Thank you. Nice to be here.
Thank you very much for joining. And I understand that you are in the forefront of combating COVID-19, and it means a world to us that you can make time and join us and tell us a little bit more. So thank you very much.
Thank you.
And how your daily routine have changed because of the coronavirus pandemic, and where are you right now, and how the life is different there than it used to be?
So I'm a medical officer based in rural New South Wales in Australia. I'm currently in Broken Hill, which is a town in the far west of New South Wales. The population is about 18,000 people, and it is the the local town for a very large area of rural New South Wales, and is the referral centre for lots of very small towns and communities that may have some of our towns may only have 5 to 10 people in them, others are larger and have up to 500 people in the town. So the regional based. In terms of what's going on here at the moment, we're relatively lucky as a health service thus far that the number of cases here has been low. We've only had 3 confirmed cases in Broken Hill in the health service thus far. But what we are seeing obviously is the restrictions on life that have been placed by the New South Wales Health Authority. So public gatherings are very reduced. Restaurants, bars, pubs, cinemas, those kind of things are very much reduced. Museums and those kind of places are all shut. So town is very quiet. There's not many people around, and most people are confined to their houses and are not going out.
Understood. Thank you very much. Well, I think that this situation is similar to almost any country, given any big place. So it's good to hear that the protocol is pretty much same, and thus you can keep down the soaring the number. So, Will, if you can explain for us what you do, what you do, and what is the Royal Flying Doctor Service, and what is your role in particular, and how you're combating the COVID-19.
So the Royal Flying Doctor Service is one of the oldest aeromedical organisations in the world. We provide healthcare to rural Australians and Australians who live in remote communities and remote settlements across New South Wales. Our section in the southeast provide those services to New South Wales, and there are a number of aspects of what we do within New South Wales to provide healthcare. First of all, we provide a primary healthcare service. So we have general practitioners, we have primary healthcare nurses and associated professionals who go out into the remote communities surrounding Broken Hill to provide primary health services. We also provide mental health, breast care nursing, alcohol and drug services to all of those communities as well. We then provide support to the local nurse-led community hospitals for assistance with patients who arrive to those clinics. So telehealth and virtual consultation to those services. And then we also provide a statewide rural retrieval service using fixed-wing aircraft to retrieve patients who are unwell and are unable to be cared for in the locations where they are, back to facilities which are better suited for managing them. And that can be as simple as moving someone from a small clinic who has got chest pain or a chest infection or something that can't be managed there and bringing them back to Broken Hill Hospital. Or it could be more complex, such as somebody who's had a car accident or an industrial accident on a remote property, flying out to the property to pick them up, to stabilize them, and then flying them to a major city such as Sydney or Adelaide for major trauma and definitive care in one of those hospitals.
Understood. So basically, we know that Australia is a huge country, and depending on regarding to population size, it's quite extensive. So what you were saying and explaining, that it's like very thinly widespread. We have a small town, small habitant places, and actually building a huge hospital complex in every each of them. It doesn't make it pretty much sense. And in that case, Royal Flying Doctors, you guys flying, bring them to the places that they can get professional help. And how the situation with the COVID-19, what is your role and how the Royal Flying Doctors service is operating under current pandemic?
So our role as one of the critical care medical officers here is twofold. First of all, we are working with the small clinics to assess people, and as and when the spread of the COVID into these rural areas becomes more significant, we're expecting to be seeing these kind of patients in the rural communities. So we're then going to be assessing them, working out whether or not they can be managed at home and isolated at home, or whether they need to be moved to a more specialist centre for care. And then once we've done that, we will then be the organisation that is then going out to pick them up, to assess them, work out where the most appropriate centre of care for them is, and then moving them on to that centre. So for lower acuity patients, that could be moving them to Broken Hill or potentially moving them to Dubbo. And for the more complex, high acuity patients, we're then talking about moving them to the larger centres such as Adelaide or Sydney. The distances involved here are in excess of 700 to 800 kilometres. So we're talking pretty substantial distances to move patients around.
Yeah, it's quite long. So regarding, we understood basically what you do, and I think it's quite really interesting, and I think people have got enough information about that. And if we jump to our topic, your topic is quite interesting, is aeromedical retrieval. So can we talk about aeromedical retrieval during COVID-19 and what it is? And floor is yours, please explain us.
Yeah, so the issue that we have with coronavirus is that unfortunately we have to move these people. In a lot of the other countries where there have been issues with coronavirus, the health service is set up in such a way that people can be managed in their local area and don't have to be moved. Because of the geography, as we've said, and because of the systems that are in place, keeping these people in their local communities to be managed if they are unwell is really not an option. And as we know with infective respiratory diseases such as coronavirus, there are certain things that we really want to avoid doing. We want to avoid aerosol generating procedures such as intubation. We want to make sure that we are not having prolonged contact with these patients. And we want to make sure that if we are having contact with them, we're using appropriate protective equipment. Unfortunately, within the context of a retrieval service such as ours, we are very limited in what we can do with those procedures. Intubating people and aerosol generating procedures in the back of a small aircraft can be very dangerous. It's very difficult to intubate someone in the back of a plane. And so we really want to avoid doing that. And we want to avoid any of the aerosol generating procedures, such as intubation or non-invasive ventilation in a plane, because in a pressurized cabin with a recirculating air supply, those infective particles, those infective pathogens are much more likely to be redistributed through the cabin and therefore affect the crew that are flying.
Yeah, because the air particles of the COVID is too small for filters of airplane to actually get them out from there. So they're going to just circle them around, aren't they?
Yeah, so the planes that we use in our section are King Air 200s and King Air 350s. So they're very small, sort of 8 to 10 seat pressurized turboprop planes. They're not like commercial planes where they have large hospital grade HEPA filters in the plane to keep the air quality up. We don't have that. So the air that circulates through the cabin is not filtered in the same way. and the airflow dynamics in the cabin as well mean that air is extracted from the cabin at the back of the plane and is then filtered and then reintroduced at the front of the plane in the flight deck. So our pilots are as at risk of exposure to the coronavirus as our clinical crews are who are working in the back of the plane.
Oh, okay. Also, I was told that you and one of the authors, or the author of COVID management protocol for Australia's Royal Flying Doctor Service. So can you tell us a little bit about this protocol, where we can read it? And is that protocol applicable to other countries and other services? And is it possible somehow that protocol can be introduced to commercial airlines if there is a need? So in what extent this protocol is versatile, if you can tell us in details, please.
So we have protocols normally for all the operations that we do, because we want to make sure that we're giving the best care to our patients. Coronavirus is meaning that those protocols are changing quite significantly, particularly surrounding the way that we approach patients who are critically unwell with respiratory disease, and also the way that we operate in terms of personal protective equipment. So those procedures and protocols are as valid to us as they are to any other organisation who are flying COVID patients around the world. And that is why we are working very closely with our colleagues across the Royal Flying Doctors in the other sections of the Flying Doctors, as well as our local colleagues with Ambulance New South Wales and their retrieval service, and the other retrieval services that work in the States, such as CareFlight and the neonatal and paediatric retrieval service. So we're trying to share best practice across those organisations so that we're all doing similar things to protect our staff and also to carry on giving our patients the best care. The biggest challenge that we have from an aeromedical point of view, particularly surrounding our protective equipment, is it's all very well and good in a hospital to prescribe the protective equipment that we want to use as a gold standard. But when we move into an aviation environment, we don't just have a medical consideration. So we need to know that this equipment and this protective equipment is going to be compatible with the aviation systems that we have in place. So for example, we still need to be able to communicate within the cabin through aviation communication systems. So that is us in the back talking to the pilot, and our pilot being able to talk to air traffic control and the local strips and the radio contact with the local strips and the people on the ground. And then we also need to have equipment which is compatible with the emergency systems within the plane as well. So if there is a cabin emergency and the cabin were to depressurize, we need to have access to the oxygen systems in the cabin, and that needs to be able to work with our protective equipment. So this is not just a medical problem, this is an aviation and an engineering problem as much for us as it is a medical problem. And that is by far and away one of the most complex things that we've had to deal with.
Yeah, because we see here, as you were saying, the overlap of different protocols to combine and to create more of like applicable, right? Because sometimes, as you say, it's a medical problem, but most of the time it's a logistic problem and others. So it's a kind of complex. And you were saying that the situation is changing quite rapidly. So do you think that this protocol will be like dynamic? It should change and evolve with the pandemics such as coronavirus?
Absolutely. So we have been through about 6 or 8 iterations of our protocol in the last month. Everything is changing very quickly based on...
In just months?
In just a month. And that's based on the best available information that we get from the World Health Organization, from other people in other countries who have had similar problems, but also then the guidelines from New South Wales Health and other organisations, and we're constantly updating our procedures based on that. But we're also, one of the really important things is basing our protocols on feedback from our clinicians on the ground. So whenever we are introducing changes to protocols and to our policies, what we then do is we then give those policies and protocols to our clinicians, and ask them to simulate working to that protocol. So we put them into a high fidelity situation with a high fidelity mannequin, using all of our equipment, our normal clinical equipment and our PPE, our protective equipment. And we say to them, right, this is the scenario with this patient. You suspect that this patient has got coronavirus. They need intubating, they need moving to another hospital. This is the protocol we want you to use, go and do it. And then once they have done that, they will then feed back to us what works, what doesn't work, and what needs to change. And that has gives us a huge body of information to then take our protocols and refine them based on the environment in which we're working.
Well, basically, it's a whole cycle of DevOps, right? Development and operation. And what I like about this is that you can actually firstly try it on a computer simulation and not just use people as a guinea pigs and like you see how it goes and not learn on your mistakes, but trying to avoid those mistakes if you have a simulation. I think this is really, really interesting and a good example.
Absolutely. We're very lucky that we have some very high fidelity physical simulation equipment. So mannequins, monitors, and equipment which allows us to actually practice this on a physical dummy in the same way that we would do it in a real patient. We also have access to non-operational aircraft, so we can simulate what happens in the back of a plane. And we also have operational road retrieval vehicles as well, and large ambulances. So we can put our crews in the back of an ambulance with a simulated coronavirus patient and drive them around, drive them up and down the roads and see how they respond in the back of an ambulance, in the back of a vehicle, in real world situations, to the sort of situations that we are then putting them in.
Wow, it's really impressive. And is that protocol classified?
Currently it's just within our organization. It's one of those things that in the future we may well look to disseminate, but actually at the moment the problem that we have is that things are changing so quickly. Actually trying to get a verified, finalized protocol out to our staff is very difficult, because the moment that we have a finalized document, something changes and it's no longer up to date. So we get to a point where we just have to say, we just need to release something for our crews to use. And then in a week's time or whatever, we will go back and change it again. But we just need, data and policies released so that people can then use them.
Yeah, I understand. But giving time is that I understand your concern, because you don't want to put out something to the world which will be eventually it's not bad and it's not, let's say, not correct, but it's outdated or doesn't adjust to a certain geographical or country's situation, and therefore you don't want to be the guys that say, hey, those guys gave us. So I understand that, but you're constantly doing your DevOps, and you are right now, I think, because of your doing it and because of your experience and because of your medical equipment, you yourself have stated that you were blessed to have all those computer simulation and dummies. And I mean, let's be honest here, Will, not every country has that opportunity. So maybe, have you ever thought of some sort of general, I understand that there cannot be like very full, but a limited or basic protocol? Is it shareable, if it's possible to share? And if it's possible, we can actually link down below here and we can let people so they can use it. And maybe I'm just thinking out loud, if you have certain type of protocol on there, and if it's like in a form of open source, so other countries and other organizations, they can do a crowdsourcing and they say, hey, this stuff worked here and that stuff worked here, and probably everybody will be better off, because you cannot test it in 6 continents, isn't it? But at the same time, making it open source will let us do. So what do you think about that?
Oh, absolutely. Yeah. I don't think we're not in a position at the moment where it's in a form where we could release it beyond our organization. That needs to go through our document control and our organization. But certainly if people are interested and have questions and are interested in what we're doing, by all means do reach out to us through email, through our website, through Twitter, and start that conversation, because we want to help other people, but also we are Absolutely. We want to know what other people are doing as much as possible so that we know, at the end of the day, a problem shared is a problem halved. The more that we share, the more that we talk, the better position we'll all be in.
Yeah, excellent. So what we're going to do is that we're going to link down below Will's contacts, and we're going to talk about what contacts exactly to put. So Will, after our conversation, you will let us know where to write. So we first of all put out to our website, and also will help. We will try to send that information to other organizations and combating. For instance, what I can promise to you is that I can reach out to our Ministry of we have a ministry in Uzbekistan, which is like Emergency Situations Ministry, and they are in the forefront, and they are doing all the aeromedical retrieval. So I think they will benefit from it most. And let professionals talk. We understand that it's not a knowledge for everybody. That knowledge won't do anything for me as just a citizen. But for professionals who are fighting, who are trying to retrieve their citizens or get the patients out there somewhere, it may save lives. So we will put link down below, all the contacts so professionals can talk. And as long as you're open for this, I just want to thank you for that.
Yeah, absolutely.
Because as you said, it's a global problem. It's a pandemic, meaning that it's global. So right now, unfortunately, there is a huge miscoordination between countries, between organizations. I'm not in a position of let's say saying that nothing about them. Everybody is doing their best. We understand, and we were just not ready for this. I think it's a wake-up call for everybody, and everybody is doing their best. No means would like to say anything negative about people who are fighting in forefront, but I think if we talk more, if we share, if we discuss, if we tell that, hey, in Uzbekistan it worked in a certain way, in Russia it worked in a certain way, in US, in Australia, in combination, we will create a sort of like a crowdsourcing platform where we can bring all that information, and in the end of the day, everyone will benefit.
Absolutely.
So that was an amazing talk. Thank you very much, Will. Unless you have any other suggestions or your wishful thinking, or like in the summary, if you wanted to tell, so let people know something, what's your message would be?
Yeah, absolutely. I think the things that we've learned is that whatever we do with these patients, transporting coronavirus patients, number one, is a black hole for time. Anything that you do, which would be normally a simple mission that may take you a couple of hours, balloons to take a prolonged period of time. And that has a huge impact on the staff, it has a huge impact on the operations, and it has a huge impact on our ability to do other things and maintain our normal operations. It's important to realize that this isn't just a medical problem, that there is significant involvement from aviation, engineering and compliance, and that has a conversation that has to happen throughout. Ultimately, we've got lots of groups of people here who have to work together. And one thing that we cannot forget is the huge impact that this is having on our non-clinical colleagues. So in particular, our pilots are hugely concerned or hugely stressed because they're being put in a situation that they've never really been in before. They've never had to fly an aircraft in full protective equipment and be put themselves into a position where they're potentially exposed to the virus. So we have to consider those things, and particularly those kind of non-technical considerations surrounding stress and fatigue management, burnout, and the environmental considerations of this for our crews, and keeping our crews safe and healthy is a huge consideration and is a huge issue for us.
Thank you. Thank you very much, Will. And shout out to everybody, every people around the world. Right now, it's not just the doctors who are fighting about it. Definitely, doctors are in the forefront. They're like superheroes, but there are so many hidden figures behind this COVID fight. And we're talking about pilots, we're talking about police officers, we're talking about supply chain, people who are delivering food to you. Everybody's exposed. No one has immunity and vaccine. And I just want to shout out to every people who are doing their work, regardless of what they're doing. Maybe it's simplest like food delivery. Your job is really appreciated, and I would like to shout out to everybody. Will, thank you very much. We could have talked more, but I understand you have far important more things to do. I wish you health, and I wish you and your crew the best success, and I hope that this conversation will help others to reach out and to resolve and to help world to be better place and finally win this war against COVID-19. Will, thank you very much.
Thank you very much.